May I now request Dr. Dhiman Banik, Professor of Cardiology from National Heart Foundation Hospital and Research Institute, Dhaka, Bangladesh, to have his lecture on steps of Culotte. So in this session, we are going to learn and understand in different strategy techniques of bifurcation stenting.
Facilitators and learned audience. Thank you to IPDI for giving me the opportunity to speak here in this August gathering. Today my lecture is on steps of Culotte. I do not have any conflict of interest. Bifurcation angioplasty accounts for about 15 to 20% of the total PCI. The bifurcation PCI in these circumstances is very challenging, technically difficult, and very time consuming. Uncertainty about the best treatment strategy, our previous speaker shows, strategy should be based on personal experience, and there is lack of robust clinical data. Bifurcation strategy dictated by the side branch, mainly due the side branch calcium, side branch length, side branch diameter, and side branch takeoff angle. No two bifurcations are identical, require individual approach. If the bifurcation angle is from the main and side branch is less than 70 degree, then the wire cross is easier, and it is more difficult when the angle is more than 90 degree. These are the steps of Culotte. There are mainly six steps of Culotte. My first case this is the CAG showing that there is a tight 99% stenosis in the ostial LCX covering the proximal part of the LCX. Distal left main is slightly tapered, and there is the LED is also slightly tapered. So I decided to go for an upfront stenting, bifurcation stenting. The first step is the wire the both vessel. My work was wire is run through floppy wire in this setting. Wire in the LCX are very difficult to go, and I, with the help of the microcatheter, I crossed the wire in the LCX. After wiring, I pre-dilated the ostial LCX with 2 into 15 millimeter NC balloon, and then the next step is to deploy a stent to the most angulated branch, that is the left main to LCX. 3.30 millimeter drug eluting stent is put on the left main to LCX covering the ostia. Then immediately after the stent, you can see the ostial LED is slightly pinched, and rewiring is done through the stent studs, recross the LED, and remove the jailed wire in the LED. The stud is open. This is the third step. And add drug eluting 3 into 38 millimeter LED balloon. Stent is placed in the left main to LED. Stent is deployed. The final fifth is the recrossing of the wire. The recrossing of the wire, there are two thoughts. That one thought is during this placement of the second stent, I have to remove the wire in the LCX as the patient was hemodynamically unstable, having chest pain in the table. So I keep the wire in the LCX as a guide for the recrossing. I recross the second stent to the double stent wire through the LCX, and I open and jailed wire is removed, and the post dilatation done with 3 into 12 millimeter NC balloon. And finally, kissing done with 1:1 size balloon, and final pot is done. So I did an IBUS for this patient. You can see that the stent is well apposed, and this is the final result. So this is the again second case of Culotte, and this is the left dominant patient with a short left main, 40 to 50% stenosis, that is distal segment. LED has a 99% stenosis as the ostia. LCX has slightly 40 to 50% lesion. Left system is non-dominant. So I wired the both vessel with the run through floppy wire, and I went for a provisional stenting from left main to LED, covering the ostia of the left main. Stent is deployed. And image after stenting, you can see that there is some pinching of the ostial LCX and patient having chest pain in the table. I removed the wire in the LCX, had done the pot with 4 into 8 millimeter NC balloon. And image after the pot, significant plus shifting into LCX ostium. Then I planned for an bailout stent with a Culotte technique. LCX were rewired through the stent stud, and a 2 into 5 millimeter NC balloon dilated, and did a fast kissing with a 3.5, 15 and 3 into 12 millimeter NC balloon. After fast kissing, this is the image were removed from the LED, and 3.5 millimeter 18 left main to LCX stent is done, stent deployed, and sequential kissing done with balloon, and finally pot done into left main. This is the final result. And I have done an eye bus for this patient, well opposed left main LED. So this is in the second case, it was the bailout stenting with Culotte. It is the decay Culotte, sequential kissing with pot done and repot done. So their bench test suggests that double kissing approach can significantly facilitate the performance of a Culotte technique. The additional kissing balloon dilatation allows a significant reduction in the total procedural duration, while resulting in better optimization overall final state apposition. In this respect, decay Culotte may be superior not only to conventional Culotte, but also compared with decay crush technique, which is currently often performed. The clinical validity of the present findings remains to be confirmed with a large vivo population trial. Regarding Culotte, Culotte is a suitable when both main branch and side branch almost of same size. It is technically suitable when the angle is less than 70 degrees. Culotte technique provides a perfect coverage of the carina and the side branch ostium at the expense of excess metal mass covering the proximal part. Culotte can be performed as an up-front double-front strategy or as a bailout technique after one stent deployed from the left main to LED, and rewiring of the both branch start, so the stent start is difficult in time and time consuming. Pot is mandatory. Rewiring should be done through the distal start. So thank you all from our cath lab team. Thank you for our patience hearing.
Thank you, Dr. Dhiman Banik, for the nice presentation and making us understand so clearly regarding the steps of Culotte.